anesthesia department. So I leave for you to do the honors, sir, for introducing Dr. Kailash, who's our guest speaker today.
Swati, one thing left. I am the convener of the pain medicine by the National Board of Education in National NBE. I am the
Sorry. My
national
humble
convener,
apologies. I missed
number
that.
one post in the country.
Right, sir. So today's topic would be lumbar sympathetic neurolysis. We'll be delving into the anatomic considerations and the clinical indications. Then we'll go into techniques and outcome measures, and of course discuss about the safety protocols. So I leave to Dr. Gedu to introduce Dr. Kailash and then open the topic.
Yeah, I must. It's a pleasure for me to introduce Kailash Kothari because he's, of course, he's my senior. As I told you, he's an 80-year-old man. But otherwise, he was even a president and a ISSP secretary and all those things. And he practices exclusively pain only. And he has been doing an excellent job in the pain management. That much I can tell you. In fact, I had my knee problem. Even he has given me PRP twice also. So I can say that he has done a real good job. So I think Kailash, it's time for you to start.
Thank you, sir. Hope we are made host. Okay.
Start.
Yes, I am starting, sir. Can you see my screen?
Yeah. Yes. It starts with only thank you.
Okay.
Yeah, now it has started.
Okay, I'm starting now. So thank you, sir, for kind introduction, and welcome all delegates, all the fellows who are pursuing pain management course. So today we are going to discuss about percutaneous. I think everybody has to keep their.
Please mute yourself, except for the speaker. The rest, everybody, please mute yourself.
Okay. We are going to discuss about percutaneous lumbar sympathetic ganglion block, chemical neurolysis, and radiofrequency ablation. So basically, history goes back to 1924 when Brunn and Mendel they have used this technique to use lumbar sympathetic block as a paravertebral approach, and they blocked mixed spinal outflow in the lumbar region. During a similar time, uh, Kappi also used the same technique, and Kappi's technique is very famous, and many people use this still today in remote places. It is a blind procedure, and during World War II, this has become more commonly used because with Bonica and Moore and Arnoff, because people who got injured during the war, they were treated with sympathetic block for causalgia and post-traumatic reflex dystrophies. Now we call it CRPS. And Reed and colleague, they published a last series in 1970 for more lateral approach to avoid contact with the transverse process. So you see, this is a very age-old technique. It is not a new technique, and pain manage goes back quite a century before, almost a century now. So it is very old technique. Pain management, we think it is a new branch, but it is already being used for 100 years now. So I already told you about the two technique, Kapi and Mandel. So let's come to anatomy, which we have to know in detail. So this is placed in the anterior lateral aspect of the lumbar spine, the lumbar sympathetic chain. This is a three-dimensional CT scan picture where you can see that lumbar ganglion here, sympathetic ganglion, and in CT scan you can see on the anterior lateral aspect of the vertebral body. And this is iliopsoas. You can see my arrow. This is iliopsoas, and just anterior to the iliopsoas, on medial to iliopsoas, you can see the sympathetic ganglion. So this location is very important when we are doing a lumbar sympathetic block, because many times there's a variation in the number and the placement of the lumbar sympathetic ganglion. So they are all both variable in number and position, and most reliable anatomical site for the lumbar ganglion is L2 and L3 vertebrae. We rarely find 5 ganglion on each side of the same individual in the same individual. In most cases, there are only 4 ganglions which are found, and the chain always lies anterior to the psoas sheath and deep to the medial aspect of the psoas major muscle, which I just showed you, anterior to the psoas iliopsoas and medial to the iliopsoas muscle. So this is very important to know, because when we place our needle and if it is little posterior or little lateral, we are going to inject our drug in the psoas muscle. So to avoid infection in the muscle, we should know our anatomy well. The there is a fusion of the L1 and L2 ganglion in most patient. So the L1 and L2 ganglion, they fuse and make a very big ganglion. So many time when you are doing any block, we have to make sure that we are blocking L2 for sure, because there's a fusion and most of the sympathetic outflow is happening at the L2 level. I'll come to that. The ganglion are aggregated at L2, L3 and L4 5 disc. And at L2, the ganglia lie anterior margin of the vertebral body at the junction of the lower 1/3 and upper 2/3. So you see, this is L2. So this is the picture which is not correct. If you take upper 2/3 of the L2 and lower 1/3 of the L2, this is where the location of the ganglion, which is most common. And if it is fused with L1, then it is a big ganglion here. Then at L3 level, ganglia lie almost on the anterior margin of the junction of the upper 1/3 and lower 2/3. So L2 it is on the lower side and L3 it is on the upper part of the L3 vertebra. So when you are doing especially radio frequency ablation, this location is very important. Where to place our needle, it is very important. Then L2 you place on the lower 1/3 and in L3 you place on the upper 1/3. And there is a considerable variability in the size of the ganglion because of the fusion of different ganglions. They may be as long as 10 to 15 millimeter, and other can be only 5 millimeter long. So you might have to do multiple lesioning at the placement of the needle, just above it and just below it. So you sometimes we do 2 to 3 region or rotate the curved tip so that we can create a larger lesion. The anatomical position of the L4 and L5 associated ganglion is more variable, because many times L5 is very posterior compared to upper 4 lumbar ganglions. Now, this is very important slide because it shows us what is preganglionic and postganglionic fibers are innervating. So basically, they innervate deep somatic structures, skin, and viscera. So that is why we use this block for the blockade of pain coming from sympathetic pain coming from lower limb and also from the viscera. So if you see here, there are preganglionic fiber. They are traveling from the corresponding nerve as white rami communicants, and they communicate with a considerable convergence in the paravertebral ganglia. So you see here, these are the preganglionic fiber. They are coming from here and they are converging in the spinal cord. And they also converge with the postganglionic efferents and in the paravertebral ganglion. So this is paravertebral ganglion. So they are converging here and they are continuing as a gray rami. Now when there's a considerable crosstalk between the preganglionic, postganglionic, and the ganglion, there's a when you are blocking these nerves, sometimes the preganglionic, which are also carrying the somatic symptoms from the skin and from the muscles, sometimes and the peripheral nerve also, because this nerve, the gray rami and the white rami, they are running through the nerves also. You can produce neuralgia. So that's a clinical importance for that. So you have to understand what are the conversions which are happening. So preganglionic, they run as a white rami, and they do convergence at the ganglion level with the spinal nerve. And postganglionic fiber, they leave the sympathetic trunk as a gray rami. You can see this. Sometimes there are sprouting fibers in the ganglion, BRG. So many times there's a sympathetic overactivity, which is because of the DRG inflammation, because of the disc prolapse. That is why you feel burning, tingling, and other sympathetic symptoms in the area where the no, this DRG is supplying. And many times these whatever fiber, preganglionic, postganglionic fibers, they skip L3 and L4 ganglion, and that directly converge on the L2 ganglion. So but L2 is always included in the sympathetic pathway. So L2 blockade is very important when you are doing L2, L3, or L4. You may miss L3 or L4, but you should never miss blocking the L2, because most of the sympathetic flow which is coming from the lower limb, it always converge at the L2 level. So L2 is very important part. And anatomically, if you see, superiorly it is continuous with the thoracic sympathetic chain, and it passes behind the medial arcuate ligament of the diaphragm. Inferiorly, it is passing behind the common iliac vessels over the sacral ala, and continuous with the sacral sympathetic chain or superior hypogastric chain. On the right side, it lies posterior to the inferior vena cava. Now, this is also very important uh, anatomical relation when you are doing the block, because if you are little bit anterior, 0.5 to 1 centimeter also, if you go anterior to the vertebral body, you may puncture the inferior vena cava and you may find the blood. It is very important, especially when you are injecting alcohol, local anesthetic, alcohol or phenol. Intravascular injection may produce vascular complication, and you have to be ultra careful when you are passing the needle beyond anterior border of the body of vertebra. And on the left, there is a posterior lateral of it is lying posterior lateral to the aortic lymph nodes. And this is microscopic structure of the autonomic ganglion. So I'll just skip this. You can read in the textbook. But this is also important aspect of the sympathetic chain, especially autonomic ganglion, that there are different neurons and stellate glial cell, and they have different function. So basically, stellate glial cells, which are in the periphery of the ganglionic neurons, they have a very important role to support and regulate the neuronal activity within the sensory, sympathetic, and parasympathetic ganglions, and they act as a bridge between the neurons and their environment. So just this is more of a microscopic. We'll just skip this. So another important aspect, preganglionic sympathetic neuron, they release acetylcholine. Postganglionic, they release noradrenaline. And the postganglionic fibers, which are gray ramus, they are non-myelinated. That is, they are not covered. And they reach requesting the fellows to mute their mic, please. Okay, so basically, if you see these gray MI, they reach their target in several ways. They pass through the spinal nerve and they reach the blood vessels, sweat glands, or hairs. They can travel via medial branch to the viscera to innervate the blood vessels or plexuses. They form the plexuses like this, sprouting fibers, and they can reach the periphery. The majority fibers, they accompany the blood vessels, arteries, and the lymphatic duct to reach the distance effectors, that is organs. Then if you see what is the function of post-ganglionic sympathetic fibers, it is vasoconstriction of the blood vessel. It is secretomotor to sweat glands. It is motor to erector pili muscle, which is a sign that it causes goosebump, because erector pili muscle is a tiny band of the smooth muscle attached to the base of the hair follicle, and the upper dermis. The fiber which follow the motor nerve to the skeletal muscles are vasodilator. Okay, so the fiber which is following the blood vessel is a vasoconstriction, and fiber following the motor nerve are vasodilators. The fibers which reach the viscera are responsible for the general vasoconstriction, regulation of the glandular secretion, and inhibition of the smooth muscle contraction in the GI symptom. So basically, these are the different effects, and you can relate to the symptoms of CRPS or relate to the symptoms when you are doing sympathetic block. So when you block, cause vasodilatation. So you feel the warmth in the leg. It is secretomotor to sweat gland. So you feel dryness when you block it, and this goosebump is a sign when there's a lot of adrenal secretion, noradrenal secretion, so that is blocked. And so these are all symptoms you can correlate when the sympathetic nervous system is overactive or it is blocked. Now, coming to the procedure, first, in what indication we do it? We do in peripheral vascular disorders. It may be arteriosclerotic, Raynaud's, Berger disease, diabetic neuropathy, perioperative vascular surgery, CRPS type 1 and type 2, post-traumatic syndrome. In some condition which are not very well documented, or the evidence is not that great, is hyperhidrosis, post amputation in early stump pain, phantom pain, frostbite, sympathetically mediated pain of any origin. So this is very important, sympathetic mediated pain. So when you are taking this procedure and advising the patient to undergo this, always make sure that you talk to them and make them understand that the block is going to work only when it is sympathetically mediated pain. So it is going, the diagnostic injection is going to differentiate whether the patient's pain is sympathetically mediated or it is sympathetically not mediated. Contraindication, as in any procedure: local infection, coagulopathy, vital function instability, or psychopathology. So coming to the technique, we do under fluoroscopic guidance. We have to prepare the patient, ascertain the type of analgesia or sedation. If we are planning to do that, I do under local anesthesia without any sedation, unless patient is very, very nervous or anxious. Start the IV fluid with normal saline, as hypotension may occur with the patient with the procedure, and always use the monitors properly as standard anesthesia protocol. We have to place the patient prone with we placing the pillow below the abdomen to flatten the lumbar lordosis. Prepare the area for the needle entry in the sterile fascia. So this is the preparation. Always preload, that is important. Drug and equipment has to be ready. We normally, what I take is a 5 ml syringe for skin infiltration, hypodermic needles, different gauge and different length, lidocaine for local infiltration, and normally you need a 15 centimeter 22 gauge needle. We have two types of needle. It is available here, which is Bygone and BD, and there are some local manufacturers are there who you can get these needles from them also. Then you need the non-ionic contrast solution. When you are placing the needle at the anterior border of the body of vertebra, you have to inject the contrast and see whether your placement is right. Avoid and is it going in the vessels or not going in the dura or epidural space or an intrathecal space. So you need to make sure that your drug is spreading in the right area. And then you have to have bupivacaine, methylprednisolone, or any chemical neurolysis you are planning, phenol, alcohol, or if RF you are planning, you have to have RF active tip cannula, which should be 15 centimeter long, and we use 15 millimeter or 10 millimeter active tip, and you have to have a ground plate and RF machine, of course. So this is how the patient is placed, prone with the pillow below the abdomen. You have to start fluoroscopic pictures. First, take AP view. Your spinous process has to be in the center of both the pedicle. That's a pure AP view. Then you move your C-arm cephalad so that your end plates are squared. Always target, make sure your target, if it is L4, then you square the vertebra at L4 level. If you are doing at L2 level, then your you have to look at the L2 vertebra, so square that end plate. At same at one in one image, you are not going to square all the end plates. So make sure that whatever your target vertebra is, that vertebra should be squared first, and then you have to place your this transverse process in the center of the vertebra, and the next step is to make it oblique. How much oblique? Till your tip of the transverse process is seen being absorbed by the lateral part of the body of vertebra. So the tip of the transverse process and your lateral border of the body of vertebra should be aligned in one line. Once you get that, then just below, if you are doing L2, on the lower border of the vertebra, you target, give local anesthesia, and in end on or tunnel view vision, you have to place your needle and go directly inside. And once you reach enough depth, then change the C-arm to the lateral view and make sure that your tip is lying and at the anterior border of the body of vertebra. You don't cross the anterior border of the body of vertebra, otherwise you may go in the inferior vena cava. If you are little lateral, you may go in the muscle. Okay, once you are there, then you have to inject the contrast. It has to cover the anterolateral aspect of the body of vertebra. It should spread more than one level. Normally, when you inject around 1 to 2 ml of the contrast, it spreads two levels of the vertebra. If it is localized, it is not spreading, there is something wrong. If it is going too much medial, not going up and down, you are not in right plane. If it is going lateral and you see the muscle fiber, that means you are in iliopsoas. So make sure you study the dye spread well, and then decide whether you want to go ahead with the injection of the local anesthetic or neurolytic drugs. So this is very important. So again, I am uh, focusing on this placement of the needle. The needle should be placed at the bottom 1/4 of the L2, upper 1/4 of the L3 and L4, and lower 1/3 of the L5 vertebra. At L5 vertebra, you don't have to go at the anterior border of the body of vertebra. You have to place at the junction of the posterior 2/3 and anterior 1/3. That is where the ganglion is. The ganglion, it just start going posteriorly at the L5 vertebra, and then it continues on the sacrum. So once you get good spread of the dye, then you can inject your local anesthetic. Of course, the another point is in AP view, you again confirm the dye spread. Here the needle is usually at the facet joint. You see the facet joint. So if it is pure AP, the needle, when it is at the anterior border of the body of vertebra, the tip is usually seen at the junction at the facet joint line. So this is facet joint, needle usually seen here. Okay, so that is another correlation of the lateral view of the tip and the AP view of the tip. In lateral view, it is at the anterior border of the body of vertebra, and in AP view, it is at the facet joint. So normally at each level, before injection, we always do negative aspiration, inject 2 to 3 ml of the contrast, see the good spread. If there is no vascular spread and spinal canal spread, which is unlikely unless you are too medial and you are grossly wrong, it is almost impossible to reach the spinal canal. So you make sure that your direction at the first go, it should be proper in the on, and oblique C-arm should be enough, so that your tip of the transfer process is aligned with the lateral border of the body of the vertebra. So once you confirm, then you inject around 3 to 4 ml of local anesthetic. If you are using only one needle technique, that means you normally we use at L3 level. If the spread of the dye is going on the L4 and L5, then we inject around 15 to 20 ml of the local anesthetic with steroid. Sometimes we inject 15. Most of the time I inject around 15 ml. It is enough. If you are using neurolytic, then you can inject around 10 to 15 ml of the local anesthetic. 6% aqueous phenol you can inject. Now, when you are coming to chemical neurolysis, there are two drugs for normally we use: absolute alcohol, ethanol, or phenol. The choice between two neurolytic agents depends on factors such as desired duration of action, localized spread, and physician's preference. What do you prefer? Normally, the phenol is corrosive to the arterial wall. So, if any major vascular structure is there, normally we prefer alcohol. Okay, and this information, thanks to Dr. Gedu, he taught me this. It is not given in any of the books. It is his experience and his knowledge. So, thank you, Dr. Gedu. Uh, so, coming to absolute alcohol, the alcohol normally works by extracting the phospholipids, cholesterol, and cerebrosides from the nerve membrane. So it basically dehydrates the nerves, and the process leads to protein precipitation and subsequent neural destruction to interrupt the pain signal. So it is administered in controlled amount at each level. So normally when I'm using alcohol, I use around 3 to 4 ml at each level, L2, L3, and L4. But if I want to inject with one needle technique, I can inject around 10 to 12 ml, up to 15 ml I can inject. We need to see properly that it is going and spreading at all, especially L2 to L4 level. So basically it is key characteristic of the alcohol we should remember is low viscosity. It spreads easily through the tissue, and because the injection can cause severe local burning sensation, it typically require administration of the local anesthetic to manage the patient comfort. So I always inject bupivacaine or ropivacaine before I inject alcohol. So it is very comfort to the patient. Still, it is very burning, very much burning and painful. It's very painful. So you have to inject in small aliquot, give some time for the patient to settle, and then use another dose. So small aliquot should be used, and it's generally used for its long-lasting clinical effect. Now, phenol, also called carbolic acid, it causes protein coagulation and localized axonal destruction when used in neurolytic concentration for therapeutic nerve block. And what is the concentration? We use 6% phenol. Many people use 8% phenol. I normally use 6% phenol. Uh, there are two types of preparation. One is in almond oil and one is aqueous. I normally use aqueous phenol because it is easy to inject through a small needle like 22 gauge needle. And we use small aliquots, 4 to 5 ml at each level, or as with alcohol, we use around 15 to 20 ml on each side if we are using single needle technique. And unlike alcohol, phenol has an immediate local anesthetic effect, which often makes the chemical injection itself relatively painless for the patient. So patient may feel pain reduction even with the phenol injection. And when it is prepared in almond oil, it is highly viscous and normally it does not spread vigorously through the tissues, and the effect remains only in the localized area. So that's the safety margin when you are using almond oil phenol. Coming to radiofrequency lesion, the procedure is same, needle placement is same. What we use is 15 centimeter RF cannula. We use curve tip because you can use the curve tip to create a larger lesion, and usually we use 10 to 15 millimeter of active tip so that larger lesion can be created. Once you place the RF cannula at the anterior border, you stimulate it with 50 hertz for sensory stimulation, 2 hertz for the motor stimulation, and you have to avoid any stimulation of the ventral root, dorsal plexus, genitofemoral nerve when you are doing motor stimulation. You have to do up to 2 volts, 2 hertz up to 2 volts. And Patient may feel slight paresthesia at the back during sensory stimulation. That's normal. And once your stimulation is proper and you make sure that it is not going in the lower limb or in the genitofemoral area, you use bupivacaine to anesthetize the area, and then at 80 degrees centigrade for 90 degrees, you do first lesion, you rotate the tip and do a second lesion. So you cover much bigger area and create a larger lesion. Many times multiple lesions are required to create large lesion, especially in if you have anatomical information in mind that the ganglion may be fused and they may be much larger, 10 to 15 millimeter long they may be. And now newer technique like cooled radio frequency has the advantage that it can create a larger lesion and it can burn most of the ganglion in one go. Now coming to the complication, there are three types of complication you can expect. One is neurological, second is renal, ureteric complications, and third is vascular complication. So neurological complications, they are not very common, but when they happen, they are sometimes troublesome even for management. So neuritis may because of the spread of neurolytic agent to the somatic nerve or lumbar plexus. So if you see the cross talking of the gray rami and white rami in the anatomy slide, that is the cause of incidence of neuritis with alcohol, especially because alcohol can spread rapidly to different tissue planes. Okay, so because the somatic nerves and the pre and post ganglionic nerves, they are very much connected and there's a cross talking there. Then neuralgia, especially genitofemoral neuralgia, when you are doing a lesion at the L2 level and L3 level, it is very common, especially L3, L4 level. So you have to be careful that when you are doing stimulation, you you should not have a stimulation going toward the genital area. And when you are doing chemical neurolysis, there is a chance you may develop genitofemoral neuralgia. Normally, it lasts up to 2 to 6 weeks and then it settles down. But sometimes it is difficult to control, and patient may have long-lasting neuralgia. And sensory loss or motor weakness at the quadriceps muscle because of the local anesthetic or neurolytic agent is one of the side effects. If your needle is little lateral and it is going in the psoas muscle and blocking the lumbar plexus. Another cause of neuralgia may be because of the spread of the neurolytic agent or local anesthetic to the rami communicans, which connects to the lateral cutaneous nerve of the thigh. So this is another thing which you should remember. Now these are very uncommon and due to improper training in dural puncture, paraplegia, inadvertent intradiscal puncture. Intradiscal puncture can happen if you are the needle is going at the level of the disc. So normally I recommend that when your needle is you are planning your entry, you have to make sure that your needle is not in the line of the disc. It should be either above it and to at the level of the vertebral bone, not at the disc level. Because even if you are going laterally, lateral to the vertebral body, if you are at the level of the disc, you can puncture the disc. It can be problematic and sometimes infection is very dangerous and difficult to manage. Low back pain, muscle spasm may happen 4 to 5 days after the procedure. Normally they settle down. When you are injecting chemical neurolytic agent, when you are removing the needle, make sure that you are flushing the needle with local anesthetic or saline so that the chemical neurolytic agent is not leaking through the channel when you are removing the needle and prevent the sinus formation. Then renal ureteric complication. If you are too lateral, you may penetrate the kidney or ureter. A patient may have hematuria, which may be transient, renal colic, dysuria. Impotency is another complication because of the genitofemoral nerve block, and so ideally you should avoid in males neurolytic agents. Retrograde ejaculation is another complication which is very rare, but it is mentioned in textbook. Then coming to vascular complication, I told you about the inferior vena cava puncture and complication because of the injection of the drugs in the inferior vena cava. because of the anatomical location of the inferior vena cava are very near to the sympathetic chain. Retroperitoneal hematoma because of the bleeding, by puncturing the veins near the nerve, especially in patients who are on anticoagulants or bleeding diastasis. So it is very important that you have to identify this high risk patient before the procedure to be done. Hypotension uh, can be managed easily with the fluid, and systemic and toxic reaction to the intravascular injection of the local anesthetic and neurolytics are another common complications. So the last slide, uh, some helpful hints. Get proper training, should not be performed by a blind technique. Now nobody does it. When performed under fluoroscopy, every step should be confirmed meticulously. Advantage of percutaneous RF lumbar sympathectomy over neurolytic are many. One is lesion is controllable. You can repeat it. No potential risk of neurolytic agents spreading to other neuronal structures. Risk of hypotension is much lesser. Incidence of genitofemoral neuralgia is also very less because unlike fluid, it does not flow in the area where the genitofemoral nerve is there. And radiofrequency ablation of sympathetic ganglion at L4-5 for the lower extremity pain. There is variable anatomical position, and because of this, it makes this technique very challenging. Reliability of the L2 and L3 sympathetic ganglion is our key uh, take-home message. Always block these L2 and 3 properly, so you can get a good successful sympathetic block. And attention must be paid to the location of the aorta inferior vena cava so that you can avoid vascular complications. And if you can watch the video on our Pain Clinic of India site, it is properly step by step it is mentioned, so you can see here on the YouTube. Okay, so you can, if you want. So I'll not show this, but there are a lot of videos here. You can see educational videos, step-by-step approach for most of the procedures can be seen on this channel. So hopefully this is over. I'm done, sir. Renu
Yes, sir.
sir. Okay,
Sir,
Anshul.
actually, yes, sir. Yes, sir.
Yeah. So any question?
Anybody having any question, they can write their question chat box.
Kailash,
So,
Yes, sir.
before any question comes, I must say that it was one of the wonderful presentation you have done.
Thank you, sir. Thank
yes,
you.
sir.
Thank you.
I mean, you practice exclusive plane, so you're really doing very good presentation. The slides were excellent. Procedures was also very good. Well, there is only small thing that I want to add. Being
Mm-hmm.
being from a Tata Cancer Hospital,
Mm-hmm.
where we do a lot of these things for the cancer patients also. Like if you got a CA colon, you got a CA bladder, you got a CA
Mm-hmm.
uterus, segment
Mm-hmm.
colon. In
Mm-hmm.
such condition, you cannot do anything superior hypogastric plexus block also. So in
Mm.
such patients, we have given these patients also a lot of things. So
Yes, sir.
that one should be added. But of course, since you don't practice, I can understand that. But
Mm.
there are some contraindications also which I just wanted to add. Like for example, if a patient has got an infection at the injection site,
Mm-hmm.
one. Second, you got a coagulation profile problem.
Mm.
Third, if there is a you got a severe heart or lung disease. In such
Correct.
condition, because whenever you give this block, there is a vasodilatation, so that will lead to the cardiac arrest. So that one has to be then. Of course, bacteremia and coagulation profile has to be noted. So if that is, these are the conditions, these are not the conditions where you should be actually practicing it. But otherwise, it was a overall very good presentation. I can say that.
Thank you, sir. Thank you. And this is what sir is saying. If you see this anatomical slide, here I mentioned, but I skipped this, that small percentage of postganglionic fiber pass directly to the ganglion in the aortic plexus and superior and inferior hypogastric plexus. and that is why it goes to the pelvic organs. These fibers do supply to pelvic organ, and you can block the pelvic pain with lumbar sympathetic block. So what sir said is absolutely bang on. Thank you, sir.
Yes.
Any
Swati, any
question?
comments? Anybody else want to comment? Swati or something, Anshul or whatever?
I
I
think it
cannot
was a
see.
wonderful, wonderful lecture and covered excellently everything. Needless to mention, you brought the very highlight points into this. Most of the times, our patients who land up in such need of these procedures are the ones who will be critically very, very serious. So, a word of caution needs to be. We need to play a lot of caution over there with these patients. So, hydrating them well before you go into the theater, making sure all your resuscitative equipment is available at the drop of a hat, and keeping all the guards ready. So all these things come very handy. And of course, there are patients these patients are very, very debilitated. The intravascular volume is really, really very low. And the cardiac profile makes it even more difficult to perform these procedures. So, of course, we need to be walking on ice when we are doing these procedures. So, you really need to be very careful with these. I think that's what makes an astute uh, pain physician who knows where to do the procedures and where not to.
Thank you. So there's no question. I think there's a chat.
I don't know. Anybody else?
I don't see any. There's only one. Anybody?
Any question
No,
coming?
I don't. No, I don't think so. There are many questions.
Good. Everybody understood everything.
One thing what Kailash said is very correct, that phenol is not preferred because phenol is always having a much more complication chances with the vessels. So anything, that is the reason we prefer to use alcohol. That's
Yeah.
a perfect he said.
Right, and it's
Yes.
also very difficult to work with phenol. It being very thick, and it's difficult to use them with thick needles. It's quite a bit of a challenge using phenol, and
If you get
it gives, yeah,
aqueous phenol, it is just like alcohol. It is very thin. You can
Correct,
inject
correct.
it very smoothly. But if you are not
yeah.
getting, and if it is you're getting phenol in almond oil, then it is very thick. You have to use
Yeah.
a bigger needle. Correct. Okay
I
then.
think we are done for the day, and it's wonderful having both of you. I think I should say wizards in cancer pain management. So we all are very fortunate to have listened from you.
Thank
I
you.
think I'll wind up the session here.
Thank you.
Thank
Good
you.
night, everyone.
Thank
Gedu
you,
sir, I am
Thank
everybody.
you,
calling
Bye.
sir.
you.
Thank you, sir.
I am calling
Thank
you
you,
in
sir.
2 minutes. Okay, Anshul. Bye.
Bye, sir.
Chalo,
Bye, sir. Thank
thank
you.
you, thank you.
Bye.
Good night, everybody.